welcome back to the clinical track, our last CE lecture of the day. Our last lecture is going to be from Cory Lappin. Cory, as a little bit of history, is a graduate of the Ohio State University. He actually got both his OD and Master's in Vision Science from Ohio State. He did complete a residency at the Cincinnati Eye Hospital or Eye Institute in ocular disease and private practice or family practice. So really amazing. He's really passionate. Most of his career is focused on anterior segment disease. So managing dry eye, ocular surface disease. He actually is a member of the Tear Film and Ocular Surface Society, which I think is really amazing. Today, he's going to be speaking with us about neurotrophic keratitis, some updates, and kind of give us a way to manage our patients who are neurotrophic.
I'm Dr. Cory Lappin, and I practice at Phoenix Eye Care in the Dry Eye Center of Arizona. So as part of our dry eye clinic, we see a lot of ocular surface disease. And the condition I'll be talking about today is one of the more challenging diseases that we encounter. So in this lecture, I'm going to be covering the latest advancements in the treatment of neurotrophic keratitis. And I have no relevant financial disclosures. So first off, what is neurotrophic keratitis? So neurotrophic keratitis is a degenerative disease of the cornea caused by damage to the corneal nerves. And this damage causes a loss of corneal sensation. And then in turn, this loss of sensation and innervation eventually causes a breakdown of the corneal surface. So it's estimated that nearly 65,000 people in the US are affected by NK. But this is likely an underestimate for a couple of reasons. And the first reason is that in the early stages of neurotrophic keratitis, the signs and symptoms are very subtle and can be really nonspecific. So it's really easy to overlook or misattribute the disease to another more common condition like dry eye. And then the second reason is that until recently, there was no specific treatments for neurotrophic keratitis. So that may have resulted in it being overlooked because there weren't a lot of great options to treat it, even if it was diagnosed. And because the condition basically is going to affect the corneal nerves, we're going to do a quick review of their anatomy and function here. So the cornea is one of the most densely innervated structures in the body with nearly 7,000 nerve endings per square millimeter. And the majority of these originate from the ophthalmic branch of the trigeminal nerve, and that provides sensory innervation to the cornea. So to review this pathway, the ophthalmic nerve branches into the nasociliary nerve, which then splits into the long and short ciliary nerves. Then you have the long ciliary nerve enters the cornea at the midstroma, and at this point, it's going to course anteriorly, and it's going to lose myelination. It then forms the nerve plexus, with free nerve endings between the epithelial cells. So because the corneal nerves are the basis of this condition, let's do a quick review of their anatomy and function. So the cornea is one of the most densely innervated structures in the body, with nearly 7,000 nerve endings per square millimeter. And the majority of these nerves originate from the ophthalmic branch of the trigeminal nerve, which provides sensory innervation to the cornea. So just to review this pathway, the ophthalmic nerve branches into the nasociliary nerve, which then splits into the long and short ciliary nerves. Then the long ciliary nerve goes to the cornea and it enters in the periphery at the midstroma. And at this point, the nerves course anteriorly and they lose their myelination. And then they form a nerve plexus and they have free nerve endings between the epithelial cells. So why exactly is the cornea so heavily innervated? And one of the major reasons for this is because of its avascular nature. Because the cornea has to be transparent to maintain visual function, it can't have blood vessels passing through it. So instead, it has to rely on other sources for nourishment. And this is where the corneal nerves come in. The nerves supply trophic support to the rest of the corneal tissues, especially the epithelium. But beyond just this trophic support, the nerves also provide sensation and sensory feedback. They stimulate epithelial cell turnover. So this is like the routine maintenance as the epithelial cells are shed. And it plays a role in wound healing. And it also plays a role in blinking and lacrimation through sensory feedback. So one way to think about it is you get something in your eye and you think about it, and then you're going to start blinking and tearing. So that's one of the ways it plays a role in these functions as well. So what happens if these nerves are damaged? It basically is just going to cause a disruption of all the functions that we previously mentioned. You're going to lose corneal sensation. You're going to lose that sensory feedback. You're going to have an impairment of that epithelial cell turnover and wound healing. And then you're also going to get abnormal blinking and tearing. And it's also important to note here that this nerve damage can occur at any point along the trigeminal pathway. So it's not just the terminal corneal nerves that can be affected here. So you can have damage all the way back at the sensory trigeminal nuclei in the midbrain, and that can ultimately cause this disruption as well. And there are many ways that these nerves can be damaged. So in this list, I have some of the most common causes of nerve damage, and they include infection, injury, ocular surface disease, systemic disease, medication use, and surgical trauma. And we're going to take a more in-depth look at each one of these here. So herpetic infections are probably the #1 cause of neurotrophic keratitis. And it's normally caused, obviously, by herpes simplex and zoster. And the reason for this is that after your initial infection, these viruses lay dormant in sensory ganglia, and that includes the trigeminal ganglion as well. And then when people become sick and immunocompromised, the virus can reactivate. And when it does, it can travel along the ophthalmic nerve to the cornea. And this is where it causes herpetic keratitis. And you're going to get these dendrites like the picture we have here. So it's the presence of the virus in the trigeminal ganglion and its reactivation that can directly damage the nerves. And then injury can be a traumatic cause of neurotrophic keratitis. And with this, a lot of the times what we're thinking about are chemical burns and contact lens misuse. So when it comes to chemical burns, pretty straightforward. The chemical exposure can directly damage the nerve endings. And then for contact lenses, sometimes just chronic wear can cause some damage, but the biggest problem normally is with misuse. So if a patient is wearing an ill-fitting lens or they're overwearing their lenses, this basically can result in chronic microtrauma and hypoxia that's going to damage the nerves. Like this picture of the patient here we had who was basically wearing their contact lenses for months at a time. And you can see the level of surface disruption and ejection they're getting around the eye. It's also really important to keep an eye on your contact lens patients because it's been shown that contact lens wearers naturally end up developing a little bit of reduced sensitivity. So if you start seeing surface breakdown in these patients, you definitely want to start considering a possible neurotrophic keratitis component. And then we have ocular surface disease. And basically this can cause NK through just chronic irritation. So the big ones to think about here would be severe dry eye and exposure keratitis. The picture we have here actually is one of our patients who developed really severe exposure after a blepharoplasty and ended up losing sensation in that area of dense staining right there due to just chronic surface damage. And then there are numerous systemic diseases that can cause NK because they affect the nerves in some way. So diabetes is especially of concern for a few reasons. And one of them is that it causes peripheral neuropathy. So if you look at this lovely picture we have, it's actually of a diabetic foot ulcer, which is really common in diabetic neuropathy. And these ulcers are often painless and can go unnoticed by a patient. So this is the reason why diabetic patients are told to routinely check their feet. And just like how diabetic neuropathy can cause these kind of painless foot ulcers, it can also potentially cause ulcers to form in the cornea as well. And because diabetes is starting to reach epidemic levels, this represents a large patient population that is at risk for developing NK. So just keep that in mind when you're seeing our diabetic patients. And then similarly, you have multiple sclerosis, which is a demyelinating disease. And in some cases, it can also cause peripheral neuropathy. And then we have a few genetic and congenital conditions that can cause NK, such as Riley-Day syndrome, Goldenhar-Gorlin syndrome, Mobius syndrome, and familial corneal hypoesthesia. And while you likely won't see these as frequently, they're really good to keep in mind in case you ever run across them. And medication use is another potential source of nerve damage. And for this, specifically think about your glaucoma patients. So these are patients that are on drops for life, oftentimes many drops. And this basically can give an opportunity where they're going to have chronic exposure to harsh preservatives like BAK that can over time damage the nerves. And then additionally, timolol and betaxolol have specifically been linked to NK development, so just something to remember. And then, of course, topical abuse of topical NSAIDs and anesthetics are another cause of nerve damage. And the reason for this is because by nature, they're going to deaden nerve sensation and block signaling. So when used chronically, that can cause nerve damage. This picture we actually have here was a patient of ours who developed some eye irritation after wearing cosmetic contact lenses. And then they ended up going to an urgent clinic and they gave them topical ketorolac. And by the time they came to us, he had been using it every 15 minutes for a few days. And the only reason he had stopped was because he ran out of drops. And thankfully, his cornea fully recovered afterwards. But this goes to show you the importance of proper nerve function and wound healing and the kind of things that can happen when this function is inhibited. And then ocular surgery, another big cause of nerve damage, especially when you think about refractive surgery. So in LASIK, when they make the flap, they're going to directly sever the corneal nerves. And then in both LASIK and PRK, when they actually do the procedure, ablation is going to damage the nerves as well. And they do tend to regenerate over time to some degree, but a lot of times they don't regenerate back to the level they quite were before. So a lot of times you're going to see a reduction in sensitivity. Similarly, the nerves are severed during corneal transplantation procedures like a penetrating keratoplasty or a deep anterior lamellar keratoplasty. And one that you might not think of as routinely is non-corneal procedures like PRP and the placement of a scleral buckle. And both of these have actually been shown to be able to damage the ciliary nerves and result in neurotrophic keratitis as well. And then just a couple other potential causes here. For non-ocular surgeries are procedures like trigeminal neuralgia and tumor excision. And these can cause collateral damage to the nerves. And actually the picture you're seeing right here is one of our patients who underwent a gamma knife procedure to treat her trigeminal neuralgia. And unfortunately, not only did it not fix her pain from the trigeminal neuralgia, but it also caused damage to her sensory pathway. So she developed this really severe case of neurotrophic keratitis here, like you can see in this picture. And then some more causes here would be compressive lesions like tumors and aneurysms. And these can compress the nerves and injure them in that way. And then you can also have strokes, and that's going to cause ischemic damage to the nerves. So now that we know the causes of NK, what are some of the signs and symptoms? So traditionally, NK is broken down into 3 categories based on the Mackey classification system. So we're going to look at the signs and symptoms in the context of these 3 categories. So let's start by looking at the signs and symptoms that are seen at all stages. The single most important symptom is reduced corneal sensitivity because this finding is diagnostic for NK. And it is also what separates it from other conditions that have similar presentations. For instance, if you look at the signs and symptoms listed here, the other ones, you have injection, light sensitivity, tearing, tear film dysfunction, and neovascularization. And these are all relatively non-specific. You can see them in many ocular surface conditions. This patient here is actually a really good example. She's one of our routine dry patients that came in one day with a complaint of an extreme red eye with watering in one of her eyes. And then we also saw this inferior neovascularization as well. And when we checked her sensitivity, it was greatly reduced compared to the other eye, which helped us identify the underlying cause and differentiate it from her baseline dryness. So if you see these really kind of non-specific symptoms, it's a good idea to test sensitivity because that's what's going to separate neurotrophic keratitis from other surface conditions. So then we have stage 1, which is considered mild NK. And again, at this level, it can be pretty subtle. It's going to include things like SPK, and patients will probably present very similarly to your typical dry eye patient. They may have complaints with discomfort with prolonged computer use or some light sensitivity. And again, it's just going to be that reduction in corneal sensation that's going to set it apart from other diseases. In moderate NK at stage 2, this is where we're going to start getting greater corneal involvement. You're going to start having these persistent non-healing epithelial defects. And these defects can sometimes be pretty significant. But again, they're going to have little to no associated pain due to the reduced or absent nerve sensation. So this is where we get the phrase staying without pain from. It's often used to describe NK in general, and it's because the epithelial lesions are going to stain with vital dyes, sometimes very dramatically, but the patient's going to have very little to no pain associated with this. Another thing at this stage is this is where you might start seeing some corneal edema as well. And if the lesions are in the visual axis, then you're going to start to get significant visual disruption as well. Stage 3, or severe neurotrophic keratitis, is characterized by ulcers with stromal involvement. So patients at this stage are at risk for stromal melting and perforation, as well as scarring that could lead to permanent vision loss. So this is where we're really starting to worry about the patients at this point. It's also worth noting that the ulcers and epithelial defects in NK tend to have these kind of smooth rolled edges, and that's very characteristic of neurotrophic keratitis. And you can see that really well at the borders of the ulcer in this patient in this picture here. And again, at this point, you're probably going to have some stromal edema. And then in some cases, you can also get an anterior chamber reaction with a hypopyon. And obviously, at this point, you're probably going to have significant visual disruption. So how is NK diagnosed? Goes back exactly to what I keep on mentioning here, is that ultimately the diagnosis is based on an absence or reduction in corneal sensitivity, as that's pathognomonic for NK. And while it's necessary to test sensitivity to diagnose NK, there are actually several ways you can go about doing this testing. So the gold standard for sensitivity testing is a Cochet-Bonnet aesthesiometer, but realistically, very few clinics are going to have one of these on hand. But fortunately, there are several items commonly found in any clinic that you can use to easily and quickly assess corneal sensitivity. And some of the most common items used are a cotton wisp, and this is just formed by pulling and twisting the end of a cotton tip applicator. You can use a piece of tissue and just roll it to an edge, or you can even just use a piece of dental floss. And once you've chosen your implement, all you simply do is you're just going to touch the end of it to the corneal surface and assess the patient's response. If the patient reflexively blinks or kind of recoils, that's a good sign that they have normal sensation. Whereas if you do this and the patient barely feels the touch or doesn't feel anything at all, even if you apply a little bit more pressure, that's a good sign that they have impaired sensitivity. And when I do this testing, I normally tell the patient to let me know when they can first feel the touch. And I have them grade the sensation on a scale from 0 to 10, because this is going to give me a better sense of the perception. And this is especially a good tool to do if you're comparing between eyes. And then once you choose your implement, you simply touch the end to the corneal surface and you're going to assess the patient's response. If the patient reflexively blinks or recoils, that's a sign that they have normal sensation. Whereas if the patient barely feels the touch or does not feel anything at all, even if you apply greater pressure, that's a sign that they have some impaired sensitivity. I also tell these patients to let me know when they can first feel the touch, and I'll have them graded on a scale from 0 to 10, especially if I'm comparing between the eyes, because this just gives me a better sense of their perception of sensation. Because this is a qualitative test, it's best to first kind of practice this on some patients with normal sensitivity to create a baseline for what a normal response is, and to essentially calibrate your testing. Patients who have unilateral NK, like in zoster-related cases, these are often good cases to learn from as well, because they basically have a built-in control eye with normal sensation. But it's when you get to these bilateral cases of NK where it's helpful to have an idea of what a normal sensation response is, because you're going to lack that direct comparator. Typically, sensation is graded as normal, reduced, or absent, while other people prefer to use a numeric rating system. Likewise, some doctors like to only test the central region of the cornea, while others like to test in several areas. So it's really up to practitioner preference as long as they are consistent. And this next point may seem obvious, but it's important to remember that sensitivity testing needs to be done before you instill any anesthetic. And I know some of us have busy clinics where a lot of times techs will use drops, so just something to keep in mind. And if you don't happen to get a chance to test sensitivity before anesthetic drops are used, I'll just say it's best to bring the patient back on another day to do this testing. Don't try to wait for the anesthetic to wear off, because you just want to have a clean slate to get a really accurate response. So now that we have a diagnosis of NK, how do we treat it? And traditionally, the treatments for NK range from aggressive surface lubrication all the way to surgical intervention, depending on the severity of the condition. And the main goals of most of these treatments are to stabilize the corneal surface and prevent progression. And remember, NK is a degenerative condition, so it tends to progress over time if left untreated. So catching it in its early stages and treating it at that point before it gets worse is a key to NK treatment. So here I have listed many of the treatments that are commonly used in managing NK, and I've broken them down into a few categories. And the first here I kind of called stabilizing treatments, and this includes artificial tears, autologous serum, and soft bandage contact lenses. So with the artificial tears and serum, you're basically going to have treatments that are really good for improving the ocular surface environment, making it conducive to healing. And then with bandage contact lenses, these do an excellent job at stabilizing the surface, especially if the patient has significant epithelial disruption. This is normally my go-to when I first see a patient that comes in and is having these really big defects. I always use a topical antibiotic just to provide that coverage and prevent infection. And typically, these treatments are often used in stages 1 and 2, but they can be helpful in stage 3 as well. And then at the next level, we have some more regenerative treatments. And these are things like Regener-Eyes drops and amniotic membranes. And these are both placental-derived treatments. So they contain numerous healing factors that are kind of aimed at just giving that extra level of healing. And a lot of times, these are used at stages 2 and 3, but they can be used in stage 1 as well. Now, it's also important to know what treatments to avoid when you're treating NK. And this would include both topical NSAIDs and steroids. And the reason for that is that these can impede wound healing and also increase the chances of stromal melting, which we really want to be careful about when we get to stage 3. And then we have our surgical treatments, like tarsorrhaphy and a conjunctival flap procedure. And these are usually reserved for stage 3, where there's a significant amount of corneal degradation. And both procedures do an excellent job at protecting the cornea and preventing further breakdown. But there's some trade-offs here. And one of them is that both procedures tend to provide pretty poor vision when they've been done, and the cosmetic appearance isn't great either. And the biggest issue is that the condition tends to regress when these procedures are reversed. So, and that kind of goes over to a bigger issue. So even though the treatments I've mentioned so far are very useful in managing NK, one of the major challenges is that these treatments are meant to just stabilize the condition rather than treat the underlying cause. So unfortunately, a lot of the improvement we gain with using these is often only temporary. So the condition just kind of regresses back when treatment stopped. So in this case, is there any treatments that take a little bit of a different approach? And this is where Oxervate comes in. So Oxervate is the first FDA-approved medication specifically indicated for the treatment of neurotrophic keratitis. And then here are a few facts about the development of Oxervate as it was going through the FDA. So first off, it received fast track status. And what this means is that it provided a treatment where there previously was not. And then it was given breakthrough therapy designation. And what this means is that it is significantly better at providing treatment than any other therapy available. It was also granted priority review status. And this is given to a medication that has shown enough promise in its treatment that the FDA really wants to act on it a little bit more quickly. So they want to make some kind of decision on the application within 6 months rather than the standard 10. And ultimately, it was classified as an orphan drug. And that means that it's intended to treat a relatively rare condition that treats a smaller population, normally 200,000 or less, and that's exactly where NK fits. So Oxervate is a medication of many firsts. It's the first and only FDA-approved medication indicated for the treatment of neurotrophic keratitis. It's the first topical biological medication approved for ophthalmic use. And it's the first application of human nerve growth factor as a therapeutic treatment. And it is also the first and only treatment that addresses the underlying cause of NK. So what exactly is Oxervate? Well, that would be cenegermin BKBJ, which is the active ingredient in Oxervate. And cenegermin is a recombinant form of human nerve growth factor. And it's structurally identical to the endogenous nerve growth factor that naturally is produced by ocular tissues. And when we say that it's a recombinant form of nerve growth factor, what exactly do we mean by that? So to produce cenegermin, what they did is they took the gene sequence responsible for producing human nerve growth factor, and then they isolated it. And then from that point, they introduced this gene sequence into another host organism, which is E. coli in the case of Oxervate. And the reason why they do that is because E. coli replicate at a much faster rate. So this allows for production of much greater quantities of NGF, which then are collected and purified for therapeutic use. So this is actually a very similar process to how insulin is produced for diabetic treatment. So now that we know that Oxervate and cenegermin are nerve growth factor, what does nerve growth factor do in the eye? First off, NGF is naturally produced by the epithelium, keratocytes, and the lacrimal gland. And it acts through binding to high affinity TRKA receptors and low affinity P75 NTR receptors. And its primary function is involved in nerve maturation and differentiation, as well as maintenance and repair of the corneal nerves. But it also has other roles, including signaling epithelial proliferation and wound healing, and it's involved in blinking and lacrimation through maintenance of sensation and also through binding to the lacrimal gland. So based on all these functions, nerve growth factor seems like an ideal treatment for neurotrophic keratitis, as each of these areas is affected by the disease. So how exactly does Oxavate treat neurotrophic keratitis? So first, it repairs damaged corneal nerves and restores sensation. So at that level right there, it's directly treating the underlying cause of NK. The second thing is it enhances lacrimation and blinking. So this creates a healthy ocular surface environment that's conducive to healing. And then thirdly, it stimulates epithelial cell turnover and wound healing. So this is going to help heal those persistent epithelial defects and ulcers. So theoretically, Oxervate is a great treatment for NK, but how well does it work clinically? And the REPARO study helps us answer that question. So the REPARO study was the largest combined population study of patients with NK ever performed. And then a diverse subject pool with ages ranging all the way from 2 years old to over 65. And the subjects enrolled had many different causes of NK. And the study specifically looked at stages 2 and 3. So that means all the subjects enrolled had either persistent epithelial defects or ulcers. And what the study found was that when Oxervate was dosed 6 times per day for 8 weeks, 72% of patients showed complete healing, which was defined as 0 millimeters of staining. So this means that if they had an ulcer or epithelial defect, it was completely healed. And then when they followed up with these patients 48 weeks later, they found that nearly 80% of patients showed sustained healing. So the big takeaway from this was that Oxervate provided robust and long-lasting healing for patients with even moderate to severe NK. Now, it's really important to note that even though the REPARO study only looked at stages 2 and 3, Oxervate is approved and can be used for all 3 stages, stages 1, 2, and 3. So ideally, we're going to find it in its early stages and diagnose it there and begin treatment before it can progress. And a standard course of treatment is that Oxervate's dosed 6 times per day, every 2 hours for 8 weeks. And then the typical follow-up schedule that I use is I normally see patients in 4-week intervals. I see them at 4 weeks, so that's halfway through treatment. At that point, I can kind of check in with the patient, see if they're having any trouble or any concerns. Then I see them at 8 weeks, which is the end of treatment, where I can assess their healing level, see how they're doing. And then I normally see them 1 month afterwards to look for sustained healing. And then I determine any follow-ups and their timing after that, depending on how the patient presents at that last visit. As far as side effects and contraindications go, Oxervate is very well tolerated, and there are no specific contraindications. It's safe to use in children as young as 2 years old. And while there are no safety data for pregnant and nursing women, there weren't any adverse effects noted in animal models when clinically relevant doses were used during these periods. So just something to keep in mind. And as far as side effects go, eye pain is the most common one. It occurs in about 16% of patients. And I always talk to patients about this ahead of time. I always just kind of give them a heads up for it. And I actually let them know if they experience eye pain, that this is actually a good thing. It's a sign that the medication is working because they're starting to regain feeling in their nerves. And I kind of explain it as if you have a dormant wire and now you're running a current through it and it's kind of sparking a little bit as it gets back online. And then in the rare cases where I've had patients where the pain is pretty significant, I'll normally just have them discontinue treatment for a day or two and then restart. And that's normally adequate to get them feeling better. And they normally do just fine with that. And then there's some other side effects: hyperemia, inflammation, epiphora, foreign body sensation, and corneal deposits. And these are normally pretty mild and transient. So we've covered a lot of information. So to summarize things, neurotrophic keratitis is a degenerative disease of the cornea, and it's caused by damage to the sensory nerves. And this ultimately results in a loss of sensation. And then that basically subsequently causes a breakdown of the corneal surface. And NK can be caused by any condition that affects the trigeminal sensory pathway, from the midbrain where you have the sensory nuclei, all the way to the terminal nerve endings at the cornea. And some of the broad categories that can cause NK are infection, injury, ocular surface disease, systemic disease, medication use, and surgery. And the way we diagnose neurotrophic keratitis is through sensitivity testing. And if you see a reduced or absent sensation, that's going to be pathognomonic for NK. And then if we're going to categorize NK, we're going to use one of the 3 stages of the Mackey classification system. And at stage 1, which is mild NK, that's where we're going to have the epithelial irregularity, your SPK. At stage 2, or moderate NK, this is where we're going to start getting those persistent epithelial defects, those non-healing staining lesions. And then at stage 3, this is where we have severe NK, and this is where we're going to have ulceration with stromal involvement. And then in stages 2 and 3, you're likely going to start having some corneal edema at that point. And then in rare cases where it's really severe, you might even have an AC reaction with hypopion development. And then just to emphasize it again here, at all stages, there's going to be that reduced or absent corneal sensation. So even if these patients have significant defects or ulcers, they're likely going to have little to no pain. And that's where we get the phrase stain without pain. And then there are many different treatments that you can use to stabilize the corneal surface and prevent progression. But the only downside with many of these is that they don't directly treat the underlying cause of NK. So unfortunately, when they're discontinued, you may see some regression in the condition. And that's one of the things that makes Oxerverate a really cool advancement in the treatment of NK, because it's the first and only FDA-approved medication that treats NK, and it's the only treatment that addresses the root cause of neurotrophic keratitis. And the way it does this is by repairing damaged nerves and restoring their sensation. And it also basically helps you heal their defects because it stimulates epithelial cell turnover and wound healing. And then it also enhances blinking and lacrimation. So it's just going to make that really good ocular surface environment that's conducive to healing. And Oxerverate is approved for all stages of neurotrophic keratitis, stages 1, 2, and 3. So ideally, you'll catch it when it's early and make the diagnosis at that point and treat it before it progresses. And so that's one of the things just to keep in mind when you have these patients that tend to have this ocular surface disease, doesn't seem like it's responding to treatment, especially even if it's subtle. Just take a little bit of time to do some sensitivity testing, and you might be able to catch neurotrophic keratitis in a very early stage and prevent it from becoming much worse. And here are my references for anyone interested. So that wraps everything up here. Thank you so much, everyone, for listening. And I would be more than happy to answer any of your questions.
Hi, Cory. That was so amazing. I really loved how during the lecture you did such a great review of like the basic sciences and then made it so clinical. So many great things coming for our patients are available now for our patients with neurotrophic keratitis. We've got lots of questions. The audience was really into the lecture. So let's just jump right in with these.
All right.
First question is, tell me how you test for corneal sensitivity. I know you talked about a bunch of different options, but what do you do clinically and in tips and tricks for it?
Yeah, so personally, I really like just using a cotton wisp because it's super easy to do. I just grab basically Q-tip real quick, get the wisp ready, and I mean, patients kind of get it. I do a quick explanation with the patient, what's kind of going on, what I'm looking for. I'm like, okay, I just want to make sure your nerves are feeling everything. So I'm just making this tiny little wisp. I'm just going to touch it to the front of the eye, and I want you to let me know when you can feel it. Personally, I actually like to test the suspect eye first and not the good eye. And the reason why I do that, at least in my experience, is when I touch it to the eye and there is a reduced sensitivity or absent sensitivity, and then I go to the good eye, they kind of are like, oh my gosh, I felt that way, way more. They like kind of know instinctively. They're like, no, I did not feel that in the other eye. Versus when I do the good eye first, going to the other one, they're like, okay, they are kind of used to feeling it already. So they're really kind of searching for that versus that kind of really pronounced lack. And then all of a sudden like, oh my gosh, I wasn't, they're almost like, I'm not ready for that because I expected it to be like the other eye. The more difficult situation, and it's kind of like what I alluded to in the lecture, is when a patient has bilateral case, because then you don't really have that built-in comparator. So that's where I would really recommend doing it on patients who have normal sensitivity to start, just because otherwise it's really hard to gauge. So that's where I really kind of watch closely how the patient reacts. And I always ask them when they can first feel it, because I do apply a little bit of a different pressure. If they don't feel the wisp at first, and I'm like, do you feel anything? And they're like, no, I'll kind of push a little bit more, still ask them if they see things. So I'm kind of actively gauging the response as I'm doing the testing with the patient. A big thing I also do, if I'm really suspecting a patient has reduced sensitivity or absent, I double check that bad eye, because I want to make sure. So what I'll do is I'll do that eye, I'll go to the other eye, and then I'll go back. And if it's for both, I just always double check the sensitivity to make sure that I'm getting enough consistent data, that it's not just, okay, the wisp wasn't quite firm enough in that area. So I normally do that. I know other practitioners who will use dental floss. They kind of will push a bit more and kind of see how much it goes in there. Some people like to check multiple areas. I normally personally just check the central cornea, but some would kind of like to go and look around. Really no problem with that. The big thing for me is just being consistent with what you do. So if you always check just central sensitivity, you just need to do that, because otherwise you can kind of get lost in what you're doing. So as long as you're consistent, that's what I would say to do. And the other thing is I would have a low threshold to test. Like if you have any inkling that they might have impaired sensitivity, it's so quick to do that, to just grab a cotton swab, do that. It's not going to take you a long period of time. It's really not that invasive. It's not bad. Patients don't mind it too much. And it just gives you such valuable information that I would recommend like just being really quick to do it. And even a lot of ocular surface and dry patients for us, I'll just do that and then I'll have it recorded in the chart so I know that I've tested sensitivity. That's been done.
That's great. Yeah, really great tips there. Thank you. Let's think about autologous serum tears. When we're thinking about that and prescribing for neurotrophic keratitis, is there a concentration you would recommend using? What dosing regimen would you be using?
Yeah, so really for that, the kind of standard 20% will work. You could kind of ramp it up if you wanted to. That's really kind of your preference, but you're comfortable with doing it. I would dose it at least 4 times a day. Since, it's autologous serum, it's made from the patient's own body, basically, it tends to be well tolerated. So if you're really trying to be aggressively lubricating the surface, you can bump that up to even 6 or more times a day, because you're not worried about that kind of preservative toxicity or anything like that. Only thing that kind of becomes an issue at that point is cost for a patient, but really I wouldn't worry about that really so much, because you're dealing with a much bigger issue. But really just your standard 20, you could do 20, 25%. Concentration isn't, to me, as important as how much you're dosing it.
Okay, no, that's great. So let's think about some of our induced neurotrophic keratitis. So thinking about refractive surgery, 2 questions with this. One, is there a way to predict who is going to end up neurotrophic after refractive surgery, or any like risk factors that you would want to think about? And then 2, any studies that show how often people actually end up neurotrophic after these, LASIK, PRK surgeries?
Yeah, so at least for studies, I can say I can't think of any off the top of my head, as this is really kind of a newer area, so to speak, as now that we can kind of treat it more. That's something that's being looked at. But honestly, even the numbers of patients who actually have neurotrophic keratitis in general isn't really well known. So that's really kind of a nebulous area right now. As far as risk factors would go, of course, if their patient happens to have diabetes as well, which is just another concomitant risk factor, things like that. Now, this is just personally what I would say. There's nothing really that's, I think, been looked at for this specifically, but I would at least think a patient who has a higher refractive error and they're getting refractive surgery, you're going to have more ablation done. So potentially more damage to the nerves in that. So again, not 100%, but just kind of going through the thought process of the mechanism, I would maybe be a bit more suspect of patients with a higher refractive error. But again, that's just kind of a thought process. Nothing I know definitively that would say that.
Okay. Do you see a difference between your LASIK and PRK patients, or kind of similar?
Relatively similar. Maybe, I mean, we see more LASIK patients in general, so I feel like I see it a bit more with LASIK, but that's probably not due to cause so much as just the fact we see it more. Though to me, again, it makes sense because with PRK, you're lacking that flap. You're still doing the ablation, where I really think the ablation has some effect, but I really think it's that actual cutting of the flap where you're severing the nerves that's the bigger factor.
Yeah, I definitely agree with that. So Oxervate, I think, is just such an amazing drug. I've had a couple patients that I've used it on, and just the results are amazing. Tell us about a couple cases that were really interesting to you that you've had good success with.
Oh yeah, absolutely. A few come to mind. I'll kind of start. The most basic one was a patient that we had for dry patient for a long time. She just came in. She had been doing well, but then she just said, my eyes really red. I can't see well. She came in and she just had this perfect neurotrophic ulcer, the rolled edges, everything like that. And we just looked at it and we're like, oh my gosh, this is like, and for her, she basically decompensated rapidly. She had a little bit of staining before, but just came in nearly the entire cornea. So we kind of knew, we're like, okay, so let's get the ball rolling with the process of getting Oxervate for, in the meantime, we had used an amniotic membrane kind of, keep things stable, but helped a little bit, but really didn't need what we were getting. And then we got the Oxervate. We started her. We saw her back in 2 weeks, and there was like pinpoint staining at that point. It had filled in. So, and that was at just 2 weeks. And by 4 weeks, there was no ulcer at all. And that was halfway through, basically through treatment. And even it was, and when I re-looked back at like the Reparo study, the amazing thing is that pretty much is exactly what they found, is that onset of healing normally happens in about 2 weeks, and complete healing takes about 28 days. But when we were even at that 14-day mark, like she basically had that ulcer had filled in.
Wow, that's
so
amazing.
that was kind of like, I would say that would be your classic case. Then there's a few more unique ones. One that actually happened right before Thanksgiving, and it was just a really satisfying one, was actually the other side of the spectrum. It was a patient who was stage 1. Basically, her surface looked pretty good, occasional staining, nothing major. Again, another long-time dry eye patient, and all of her dry eye testing kept improving and everything looked stable, but she didn't feel any better. Something was just still off. And then I kind of started digging more into her history, and I'm like, so have you ever had like any like herpetic infections, shingles, anything like that? And she's like, well, I've never had it in my eye. I'm like, well, have you had it in general? And she said, actually, I have chronic zoster where in over 20 years, she's had over 100 outbreaks of shingles in various parts of her body, never in the eye from what she knew. So then I tested her sensitivity, was completely shot, both eyes.
Oh.
And then, so then basically I'm like, okay, let's prescribe it. And she was in the process of changing insurances. So she said, I might hold off a little bit. So I'm like, okay, just let us know when you're ready. And she ended up actually doing that on her own, getting it a while later. And she was on my schedule for a follow-up. And she comes in and she's just smiling. And she's like, this is the best my eyes have felt in 20 years.
Wow.
And she said, like, from the first week of her taking it, she saw just a huge difference. And I rechecked the sensitivity, been completely regained. But again, she was a mild case, which is why, if I could reiterate anything, it's test patients even at the earliest stage, because it's so easy to miss this unless you look at it. And really at that first stage, there is almost no difference between a dry eye patient except for the reduced corneal sensitivity.
Yeah, I think that's crazy because when I'm thinking of the cases that I've treated, they're severe cases. There's no question that they're neurotrophic. They've got huge ulcers. So I think that's really important for us to keep in mind for these, more mild cases. Hopefully it becomes a little bit easier from a cost perspective eventually, so way more people can have access. But that's really awesome. If you've treated somebody with Oxervate, they've gone through the 8 weeks. I know the studies show that not everyone has full improvement. What do you do at that point? If they're still not completely resolved?
Yeah, based at that point, it's normally seeing how much healing they got. Because again, when you think kind of, 72% are healed, the flip side of that means about a quarter of patients aren't healed at that point. And really what I've found, at least clinically, is a lot of times it just takes a second course. It just takes a second round of Oxervate is normally what I've found. And then they're in good shape. And sometimes I really just think it's to get those nerves back online. There's a bunch of factors. What's the underlying cause? How long have they had it? So if you think about it, like some patients, it's just going to take longer to get that system back online. It's going to take longer to heal the defects. So really, I would actually say it's pretty in line with that number that I've seen clinically. About a quarter of patients will need about 2 courses of it. The big thing with this, though, make sure that you're treating everything that's concomitant with that. If they have dry eye, you really have to optimize the ocular surface, because that's what's going to be conducive to healing. Yes, you're addressing the underlying cause, but if this patient also has severe surface disease, that's going to be fighting the healing. So you really got to make sure you're addressing the entire ocular surface while you're, addressing the neurotrophic keratitis itself as well.
Oh yeah, that makes sense for sure. If you ever do scleral contact lenses or anything in these cases too, to try and, keep that cornea more lubricated? Yeah.
So we actually do have some scleral patients that we've actually done that with. It's a bit cumbersome when they're on the Oxerverate because it's dosed 6 times per day for that. So for that, normally they'll stay, we'll keep them out of it for that, but then we have them go back into the lenses. And a lot of those patients tend to do very, very well afterwards because they kind of have that sealed off environment.
Yeah, that's great. So what about these patients that, you're going through workup, you're trying to, you decide they're neurotrophic and just Oxervate's not for them. It's something that they can't get or they're really not a good candidate for. What do you do in those cases?
Yeah. And that's basically where you kind of go to like those other treatments I've discussed. Autologous serum tears. I would definitely say in that case, I'm a big proponent of an amniotic membrane. And the reason, because it's a placental derived basically treatment that has a lot of those healing factors, it has a lot of those growth factors. So in a way, it's kind of somewhat similar to Oxervate. It's just not as concentrated and as potent in that nerve growth factor. But I've had good success with at least stabilizing patients when doing that. So I normally do that. And again, just aggressive surface treatment, making sure that everything that's going on, that surface, I'm basically giving them every chance to be healed or stable. But the other thing is you got to watch them very, very closely. Like you probably don't want to go more than a couple months without seeing these patients, 3 max, if that, just because you have to keep a close eye with them. Again, they can't feel when this stuff is happening. They don't know. The only clue they normally have is their vision is going to be disrupted. So basically just aggressively treat the surface, make sure it's in the best shape you can get it, and just watch them closely. And again, like I said, if you really need something, bandage contact lenses and amniotic membranes are really, really good treatments.
Yeah, that's amazing. Thank you so much for this.
Thank you.
I really, I'm inspired to try and find more patients that are neurotrophic to get treated because, I think we definitely can help out many, many new people. Just a couple show notes that I'm going to go over really quickly. Eyes on Eye Care is doing Eyes on Dry Eye in March. So this is kind of a great segue. Obviously we just talked about our mild dry eye neurotrophic patients. So hopefully we have some, it'll be a very similar setup to what this program was. So if you've enjoyed this, definitely feel free to sign up, free registration. That link is on the expo page at the bottom of the page. You can click there. Right now, I'm going to have everybody head over to the expo, the exhibit hall, because Dr. Durker and Geller are going to be doing their farewells for the show. And Dr. Geller has one more raffle code for you over there. So thank you so much, everybody. It was really nice working with you or, chatting with everyone this weekend. It's been really an awesome, awesome show.